I just want to say good evening and welcome everyone. On behalf of the LAM Foundation, it is my pleasure once again to welcome you to this evening's LAMposium in your living room. We are so glad that you could join us this evening. I feel so much lighthearted right now with spring around the corner and getting to be with all of you as friends. So thank you for being here. My name is Cindy Beasley. I am the Director of Education and Advocacy for the LAM Foundation, and I will be your moderator this evening. Now, this year's LAMposium in Your Living Room is designed to bring the sessions that we experienced at the in-person LAMposium session back in the fall. We want to bring those directly to you. And tonight we're fortunate to have with us Dr. Joel Moss and members of his team from the National Institutes of Health for a presentation on LAM protocols at the NIH. So to allow for ample Q&A time, because I know we've got a big presentation and I want to make sure everybody gets heard that wants to be heard, we will not have our informal patient and family group discussion this evening. So before we begin, please note that this session is being recorded. Our microphones will be muted, the chat box will be disabled during the presentation, but at the conclusion of the presentation, we will open the chat box for your questions. And we do have some that were pre-submitted as well, so we will bring those up. So, and now it is my pleasure to introduce our guest speaker, Dr. Joel Moss. Dr. Moss is a senior investigator in the critical care medicine and pulmonary branch of the National Heart, Lung, and Blood Institute of the National Institutes of Health. Since 2007, he has been head of the Laboratory of Translational Research and the LAM Research Program. Dr. Moss has co-authored over 830 papers. He's edited and co-authored several books and is a co-inventor of biotechnology patents. Dr. Moss has a distinguished career in biomedical research and leadership, including the LAM Foundation's Scientific Achievement Award in 1999 and 2010. Dr. Moss and colleagues established the natural history of LAM, the characteristics of lymphatics in LAM, and the circulating LAM-like cells in patients. He is a beloved member of our community, and we are delighted to have him with us this evening. So, Dr. Moss, I will now turn this over to you. We're almost, yep, we can see it. Perfect.
Thank you. Thank you, Cindy. I'd like to thank the LAM Foundation for this opportunity to present on the LAM protocols at the National Institutes of Health. Your mission to the NIH requires a number of people that work with us, and I'll try to introduce some of them as I proceed with the talk. For those of you who have been at LAMposium in 2025 in Kansas City, it's going to be very similar, but what I hope to do is present some updates in terms of what we've learned since then. So, let's see. First, I have no relevant conflicts of interest related to today's presentation, and we may discuss some off-label use of medications in LAM patients. So for those of you who are new to the LAMposium, what is LAM? It's a rare lung disease of women, often of childbearing age, characterized by thin-walled lung cysts, involvement of the axial lymphatics with lymphangiolymiomas and adenopathy, and abdominal tumors such as renal angiomyolipomas. LAM may occur as a manifestation of tuberous sclerosis complex, an inherited disorder, which may also occur sporadically and involve multiple organs such as brains, skin, heart, and eye. Symptoms are related to organ involvement, again, seizures or skin tumors. So to tell you somewhat about the NIH, first, we do not admit private patients to the NIH Clinical Center. Patients and healthy volunteers participate in research studies. Research subjects must be enrolled in a clinical protocol that has been approved by an ethics panel or institutional review board. And these IRBs are composed of investigators, ethicists, statisticians, and community representatives. In general, during the visit, presents have standard clinical tests as well as research tests as specified by the protocol. Results of the standard clinical tests and procedures performed in an approved manner can be given to the patient as well as other individuals that they specify, such as their physicians. Research tests by regulation are not given to the patient. So what are the research protocols at the NIH now? So first we have the natural history protocol, which is one that is usually seen by patients when they first enter NIH and involves disease pathogenesis and treatment of both LAM and TSC. There are genetic factors involved in both these diseases, and what we do as well is include some of the imaging studies as part of the admission, as well as studies of pathology that may be obtained elsewhere or at the NIH. We also study skin tumors in tuberous sclerosis, and that's done with the aid of Tom Darling, who's a dermatologist at the university across the street from NIH. And then there are clinical trial protocols as well. So discuss them as we, To discuss the protocols themselves, the main LAM protocol is 95H106, which involves characterization of pathogenesis of lymphangiomatosis. And so far, since we started the protocol, which was in 1995, we have enrolled 861 patients. In addition, there is a standard protocol, 96H100, which looks at genetic factors in the regulation of lung disease, and we've enrolled almost 3,000 patients in that protocol. And finally, there's a protocol involved with cutaneous tumor genesis in patients with tuberous sclerosis complex, and we've involved 119 patients. There's an ongoing study on bronchodilator effects of nebulized versus inhaled albuterol in subjects with lymphangiomatosis, and we've enrolled 78 patients. Finally, there's a protocol that is completed. The data is under review and looking at specifically sirolimus-sensitive biomarkers, and the enrollment in that protocol has been completed, and the data again are under analysis. What is important to the patients is that they may be enrolled in more than one protocol. So first, to give you some information about the enrollment in the LAM protocol, and these are patients with proven LAM based on current criteria, which may involve extrapulmonary manifestation of LAM, such as angiomyolipomas and lymphangiomyomas, tuberous sclerosis involving skin, bone, or brain manifestations. Criteria for diagnosing LAM and TSC have changed over the past 30 years as research has changed our understanding of diseases and resulted in better differentiation of cystic lung diseases as well as TSC. What is important also in terms of the research being done by other investigators is that upon publication, these data will be deposited in a dbGaP biodata catalyst and available to the LAM and TSC communities. So it's been 30 years since the protocol approval. Again, more than 861 patients with LAM and LAM TSC have been enrolled in the LAM natural history protocol. In this longitudinal study, 400 patients have returned 5 or more visits with additional long-term follow-up in what is in most patients a chronic disease. And patients, because their participation in this protocol, have records of disease progression documented by pulmonary function imaging, such as CT scan, biomarkers, and/or biopsies, comorbidities associated with progressive illness, as well as medication taken to address both LAM as well as the comorbidities. And again, all of this information that's being put in a paper can be given to the LAM community. So what are demographics of people that have enrolled in the LAM protocol itself? So this is a documentation of all the states. And if you look carefully, you'll notice there's only 2 zeros. We have not seen a patient in the LAM protocol in South Dakota or West Virginia. And I don't understand, with West Virginia being sort of next door to NIH, why we're at 0. Now, these are patients that are confirmed LAM by the criteria being used at that time. We've also seen patients from Guam and Puerto Rico. And if we look at a little bit more carefully on the next slide, the enrollment has come for basically all areas of the country, as you might imagine, with most patients from the South. If you look at the criteria used for the South, NIH is no longer in Maryland, it is in Maryland in the South rather than in the mid-Atlantic, which is how we normally think about that. But again, there are people involved elsewhere. What is also interesting, these are the people enrolled in the protocol from overseas. And essentially, if you look at we've had people from Australia, we've had people from Brazil, a couple people from Russia. And if you look at the numbers and where they're located, from the US, we've had 760 patients, about 86% from 48 states and 2 territories. We've also enrolled a number of patients from Canada, 6.9% from 8 provinces. Internationally, we've had 6.4% from 36 countries when you include Canada. And there's some undetermined patients, and I'm not sure exactly why that is. Patients may have moved, and that was a problem. The only difference that we have between people coming from the US versus from elsewhere is the travel expenses are covered for international patients from US point of entry to the NIH. So if they fly into Dulles, for example, point of entry is where it is. Other patients from South America may use Miami as the point of entry. So it depends where they come from. Now, what about the other protocols we have? So 96H100 may be the protocol that we use where we're not sure exactly whether the patient has LAM by current criteria. So enrolls patients with possible LAM, other cystic lung diseases, in addition to the disease of interest, to other investigators in the critical care medicine and pulmonary branch, as well as healthy volunteers. Amendments to the protocol allow us to study genetics, as well as imaging with CT scans, as well as MRIs of both LAM as well as related diseases, and possibly to be able to distinguish different diseases. Studies include both patient-derived specimens for clinical as well as research studies, and almost 3,000 patients have been enrolled in this protocol. Patient follow-up may vary depending on what they're interested in. So in the case of LAM, for example, we try to follow patients essentially. Some have followed for almost 30 years since the protocol initiated. With other diseases, et cetera, we may not do so. So what about the next protocol, tumorigenesis in patients with tuberous sclerosis? And there are multiple skin lesions that have been identified in patients with TSC. And some of these lesions may be found in otherwise healthy individuals and in patients with other diseases. Some may be found in patients with TSC, but do not meet the number criteria required for TSC diagnosis. Biopsies may help in identification of presence of mutated TSC genes and other causes for the lesions. And we've seen over 119 patients in this protocol as well. So what happens when patients come to the NIH? We have several special interactions with patients during the visit. During the Tuesday evening group meeting, it gives me an opportunity to listen to the patients, to introduce patients to activities of the LAM Foundation, and that is done by Mary Stojek, a LAM liaison for this area, and to discuss research and other clinical topics of interest to the patients. The reason this protocol has been of importance, number one, when Mary Stojek is at the meeting, she's able to give various information to the patients from gifts usually given to her by Erin. So Erin could give a shout out at that point in time. And what we're able to do is tell the patient what protocols are going on at the foundation, et cetera, stuff that she may not get otherwise at the NIH. And why has the patient helped us in terms of these interactions. First, air travel. Patients were permitted to travel by air in many cases with restrictions. Potential risks include pneumothoraces, decline in lung function, and desaturation. What was interesting about this finding is that when patients first came to the NIH, some of them came from California by train 48 hours because at that time patients were told that patients with LAM shouldn't travel. So as you probably gather now, patients with LAM are going to the NIH. Patients with LAM are also going to the Far East. Patients with LAM are going to Europe. And the only thing that we're upset about is the fact that they won't take their MD and the MT with them. We have to change that somehow. By the way, that is a joke. So in case other people can't figure that out. Regarding pregnancy, again, this has been an issue. Patients were told that pregnancy may be a problem because of pneumothoraces as well as decline in lung function. However, most recent work has suggested that patients may actually be on sirolimus at the time. And this is from Nishan's laboratory. And this suggests that there's much more way of preserving some of the risks, reducing some of the risks, especially pneumothoraces, as well as the progression of the lung disease. The other thing that we've learned is that patients are very heterogeneous. When we first started the protocol, there was LAM, and patients with LAM were told that they had 3 to 5 years to live, if that, and that was what they were told. We had one patient that came to the lab, and she was told that because she had this, she should get affairs in order, quit her job, sell her house, write her will, and then prepare to go home. When we finished the meeting with her, discharge conference, what she was told is she should get her job back if she wants, get her house back. It's always good to have a will, and maybe wait for the holidays before she's go to her home. So learning that LAM really was heterogeneous was very useful for the patients. Also, we've learned about sporadic LAM. So when we initially started the protocol, patients were told they had either LAM or TSC, and we did the brain imaging to look for TSC, look at the skin, and the patients otherwise were sporadic LAM. And what we've learned now that some sporadic LAM patients essentially are mosaics for TSC, and some TSC patients almost resemble sporadic LAM, depending on the level, and we'll discuss that later. So listening to the patients have been very useful in terms of what they're telling us. And then also the extrapulmonary manifestations are variable. And when the reason for having the group meeting is when the patients talk about themselves, they'll tell them about different problems each of them have, and they differ between the patients. So it's sort of useful for the patients to see that other people with LAM are having the same problems. Now, this obviously is not as useful as being at the LAMposium, but for some people where it's the first time seeing patients with LAM, so I think it's very useful for them. And it allows us to show the importance of personalized care. Now, in order to do this, we really have to understand the phenotypes of the LAM patients, and these are the people that are responsible. So Tatiana Worthy, so on your right, is the person that you'll first see when you're admitted or try to getting admitted to NIH, in terms of she'll get the information from us for us, and then we decide what patient has, or as much of that is whether or not the cystic disease looks like LAM. And then you see one of the nurse practitioners, Amanda Jones, or Patricia Julian Williams. So you see a number of people that will help in terms of differentiation of the phenotypes that you have. So the next thing that we're trying to go to is some of the specialized tests that you'll have. One of them is done to look at the CT scans, which are in front of you. And as you can tell by the little holes that you see here, the LAM is characterized by thin-walled cysts, and they vary in size. Well, the problem with getting cysts all the time, getting CTs all the time, is that there's radiation involved. And one of the people that we work with is Marcus Chen. And this is Dr. Chen. And he's actually a cardiologist. But what he's been able to do is lower the radiation from somewhere between 20 to 50 chest X-ray equivalents to essentially one chest X-ray equivalent. And this has taken a little bit of time, but this is helpful because it reduces the radiation exposure. And these are two films, and can you tell the difference between them? They're the same patient. Okay, so let's look at this one. This is a standard dose chest CT. In this case, it took 83 chest X-rays. Remember, this is done over time. Okay, and what we have here is a low radiation dose, 92% less radiation, and 6 chest X-rays. This has been changed over time so that the amount of chest X-rays are essentially number one. And we had a patient who had a problem with the pleurodesis, and the surgeon wanted to go in to fix it. And he wanted to have a CT scan to know what was stuck where. And we were able to give the surgeon a CT scan that he could use with under less than one chest X-ray. Okay. And what we're doing now is, you'll see it in a moment. So let's look at this one. Can you tell the difference between these two films? So what you're looking at here in both cases is pneumothorax, and we're able to quantify the pneumothorax in both cases. So in this case, it's a clinical CT scan. The pneumothorax score is about 0.32 in terms of what the involvement is, and it costs 77 chest X-ray equivalents. Okay, and this time is the low dose. The score is for pneumothorax is 0.3, and it's 5.6 chest X-ray equivalents, or 93% reduction in radiation exposure. So what we also wanted to do is we are able to score the amount of lung involved with cysts by what we call a cyst score. And this is the cyst score with the low radiation dose, and this is the cyst score with the standard dose. And as you can tell here, essentially it's on a straight line. So they're basically the same. So we don't, for the purpose of getting the cyst score, we essentially don't have to use the high dose radiation. What we're doing now, though, is we'll do a first CT scan. People have come in with a regular dose because we may be missing something, and we want to make sure that we're not. And then we can go from there with the same CIS score and do the lower dose as well. Okay. So the other thing that we're finding is that if you look at this again, this is a CT scan. These are the cysts. And one of the things we wanted to find out was whether or not what was happening around the cyst. And this is in this area, for example, where you have grayish area that almost looks normal. And we had Victor Franz was then the pathologist at the NIH. And this is one of the films that we had. So what you're looking at now is the histopathology of a lung cyst. And this little thing here is where the lung cyst, where the LAM nodule lives in the lung cyst. So it's on the wall. And what you find is that you have this area of emphysema, so to speak, the little asterisks. And this is area that's been degraded. If we look at the pathology with anti-proteases, this area has a lot of proteases being secreted, presumably by the LAM cysts, and by the LAM cells in the LAM cyst. And what we also find is that this area is stabilized by rapamycin. So rapamycin is not only stabilizing lung, it's also stabilizing the area around the lung cyst. So that it's another important way of judging how the drug is working. Then we wanted to get more information in terms of how the lung cysts are working. And fortunately, Dr. Han Wen, who's a PhD physicist, has joined the group. And he's the person now that's quantifying the cyst on the lung. And what he's also being able to do is quantify other features on the CT scan. So he's now putting it in an algorithm. And again, once he has that done, it could be given to other laboratories and other doctors studying LAM. So what have we learned from studying the CT scan? Well, first of all, we can show cyst size, and I don't have time to present everything, but the bigger cysts are associated with the FEV1. The smaller cysts are associated more with the DLCO. And in patients that have one form or another, you can actually tell what the PFTs are going to look at from looking at the cyst size. So if you have a small cyst, you're more likely to have decreases in DLCO, and you'll have deoxygenation because that D stands for diffusion. So your desaturation will occur with only or minimal FEV1 involvement. However, if you have big cysts, you're more likely to have FEV1 involvement, and it's more localized in terms of their presence on the on the CT scan. So we can determine from this, by Dr. Wen now, lung involvement with cysts, and he can quantify how much of the lung is involved here. For people who maybe want to know how this relates to destruction of the lung or stage of disease, what we found when we looked at patients who went to lung transplantation is the curve was fairly broad, but about 50% of the lung was involved with cysts when they were considered for lung transplant. That is very personalized, by the way, and it differed significantly among people, and that's the reason why the curve is not sharp. It's going to be broad. Okay. And then we found that the lung texture around the cyst is also abnormal, shows evidence of proteases, and you could see why it might be on this. Okay, you can see a pneumothorax much better on the CT scan than by chest X-ray. So on patients that came in with a chest X-ray and then we had a CT scan, more than two times the number of pneumothoraces were picked up by the CT scan. Pleural effusions obviously show very well on the CT scan. And there are also interstitial markings. Some patients have what looks like some fibrotic patterns, et cetera. We can pick them up on the CT scan, and we can also pick it up on low-dose CT scan in some patients. In patients who have tuberous sclerosis, we can find what's called multifocal micronodular pneumocyte hyperplasia, or MMPH, which in addition to being difficult to say, is a characteristic of that disease as well. And finally, we can study disease progression, stage and progression by looking at the number of cysts and the cyst score. And finally, the problem with CTs in general is that they involve radiation. So Adrienne Campbell is specialist in MRI. And first, the good news, she has been able to show by MRI what you see by PFTs on terms of the FEV1 and the DLCO. So everything in PFTs are done at the mouth. What Adrienne Campbell has been able to do with the lung is show where the ventilation takes place in the lung, and then where the blood becomes oxygenated in the lung. So for example, in some patients where they have a mass because of an infection or whatever, she can show that that area of the lung is not being used. And therefore it's not affecting the patient's ability to oxygenate. And this is important for a surgeon that may be involved and is concerned about removing good lung from the person. So what I told you then was the good news. And now I have to tell you the bad news. So Adrienne has two little kids, and she decided that the two little kids would be better growing up if they were near family. And unfortunately, near family is in Ontario. Remember, I said they have good news. That was the bad news. The good news, however, is that Adrienne is going to spend 20% of her time at the NIH, so to speak. So she's still in charge, number one. Number two, as she said, she has a vibrant group, and she's letting them stay here so that they will be able to do the CT scans. So the ability to do the CT scans that show the ventilation and perfusion, which she could do, is still going to continue. And in fact, we're trying to get 100 LAM patients to set us a bar in terms of what we're seeing. So we're telling all patients that when they come, we call her NP, and they sort of fix up with our NPs to which time is available for them. But I think that would be very valuable, again, to know where the problems are in the lung for each patient. So there was good news, and I think that's good news as well. Now, next, finishing with Adrian. So what is known about tuberous sclerosis complex? So again, it's involved with germline mutations in the TSC genes, TSC1 and TSC2. It can recur as a result of mutations in the TSC genes following formation of the embryo, in which time not all cells in the fetus will have the same mutation, and the individual will be a mosaic. And LAM itself is one example of extreme mosaicism. Other forms are what are called generalized mosaicism, where it's spread over the entire body, or segmental or asymmetric mosaicism. And I'll show you examples of both. The reason this is important, as you'll see, is that we used to say patients have TSC or patients have sporadic LAM. And now we have patients that have sporadic LAM, when we're able to analyze them more carefully with better techniques, have in point of fact TSC, and patients with TSC have a mild form that almost looks like sporadic LAM. And this will have an effect, as I'll show you, in terms of whether or not the child, if they, is a TSC or not. So certain forms of quote TSC can in fact be picked up by patients with sporadic LAM, depending on the degree of mosaicism. So that can be also determined when we see patients. Okay. So here is just for those people who have not familiar with TSC. Okay, you look at your lower left side, that's the lung with LAM. So the lung is involved, the kidney with angiomyolipoma, lymphatics as well. LAM consists of one major criteria for TSC. Everything else that you're looking at now are either major criteria or minor criteria for TSC. So part of the problem with being able to distinguish people is you don't have people who can actually follow it. So one of the things we're following now is sclerotic bone lesions. So Dr. Avila, who used to be in the laboratory, now retired, when he first came, what he was able to observe, actually not first came, after it's been a while, is that in patients with LAM or TSC, there are sclerotic bone lesions. And the nice part about that is a radiologist can easily determine what sclerotic bone lesions are. And you'll see how that is relevant to the diagnosis. And obviously, there are other things as well. The skin findings, you have to be multiple, otherwise you don't have the major criteria. Well, it turns out if you're not multiple, you may not meet major criteria, but in point of fact, you may be a mosaic. So as I go through now, we'll discuss each one individually. Okay, so what happens if a person does not meet the major standard or clinical or genetic diagnosis criteria for TSC? Okay, so let's look at that. So this is what the major criteria are. You have to have two majors and or one major and two minors. Okay, for TSC diagnosis, you either have TSC1 in blood or TSC2 mutation in blood. Except that's the way life isn't that way. What happens if you have partly possible TSC or no mutation identified by blood analysis of the blood? Well, with the help of David Kwiatkowski, who most of you may know is a geneticist that works at Brigham, and Tom Darling, who's a dermatologist, it's been possible to take some of the skin lesions on the patients that we see them on TSC and to look at the different types of mosaicism. So if you look at the people here, this is segmental mosaicism. It's only on one side of the body. And if you look at the nose here, and you look at these skin lesions here, these are the angiofibromas. And in a lot of cases, they're missed. If you look at this side, it's fairly clear. If you look here again, it's on this side of the face, it's clear. On the right, left, these are a number of lesions. Okay, so this is segmental mosaicism. And this is a symmetric mosaicism or generalized mosaicism. And you can see the lesions on both sides. The reason this is important is it does affect the frequency of the number of problems that we'll have in terms of how to talk to patients. So the nurse practitioners that I introduced before are getting pretty good at seeing these lesions, and Dr. Darling, who works across the street, is very good at coming across and helping us on the lesions that we miss. Right, so why does it have a difference? So if you have angiofibromas on one side, the total number of TSC findings are going to be much less. If you look at them that are symmetrically versus germline, they're pretty much same. And the reason this is different is if you're symmetric, we'll show that in a second, but let's look at this. Okay, so we then looked at sclerotic bone lesions as a way of looking at asymmetric versus asymmetric or germline TSC. And the reason that's relevant is you can distinguish patients with sporadic LAM, asymmetric, symmetric, and germline by the number of sclerotic bone lesions. Okay, remember, everything here is statistical. So the fact that you do or do not fall in one group may not necessarily be accurate. Okay, but as you go in different groups, you can distinguish between them. And the reason this is important is germline TSC, you have 50% chance of giving it to offspring. Okay, now genetically, it goes down when you have these mosaic formed because you have to have the ovary involved. And obviously we can't, or the sperm. And for our patients, it's the ovary. The problem is we don't want to do biopsies on everyone's ovaries, probably because I'll end up in jail somewhere. But if there are patients that look like sporadic LAM or don't have signs of LAM whose ovaries involved, and the child will have a germline TSC essentially. There are other patients that we've had where they have had children and they have what we found to be mosaics forms, or similar to what we have with sporadic LAM. And so far, the number of children that we know of are probably less than 2 out of 20 to 25. Okay, so that number is inaccurate, but it clearly shows that there's an advantage, in a sense, to the mom in terms of having a mosaic. Okay, and this is the total number of sclerotic bone lesions, again, that we've looked at here. And this is the number in sporadic LAM, asymmetric angiofibromas, symmetric angiofibromas, or germline. And obviously, these are cases where a good radiologist can actually distinguish which one of them you have, and therefore give you what the diagnosis is. And what it has done is it moved some of the patients we thought were sporadic LAM, in fact, to an asymmetric angiofibroma, or not even seeing that because of these criteria of sclerotic bone lesions as having a form of TSC. Now, again, let me give a comment. Mary Stojek has told me that I can say anything I want about her. So the reason this is relevant is Mary Stojek has 3 daughters and had, I think, 5 grandkids now. Okay, she's not an asymmetric, but she's an extreme mosaicism. So the fact that you're extreme, again, it makes it less likely that you're going to be involved in terms of giving the disease, tuberous sclerosis, to your children. Okay, so this is a picture of a bunch of the genetics. So if we look at the various genetic forms, and we're on the bottom, we have sporadic LAM here, asymmetric angiofibromas, symmetric angiofibromas, and germline. Okay, the number of sclerotic bone lesions go up, depending on what you see in terms of the type of mosaicism you have. The number of mucocutaneous findings go up the same way. And what David Kwiatkowski has found is that the variant allele frequency in blood goes up along the same line. Okay, so all these criteria, some of which are fairly easy for, again, a expert in terms of skin lesions to identify. Sclerotic bone lesions can be seen by a radiologist, so they can be done without the need necessarily to have sequencing in every person. So initially we had PFTs, scans, exercise testing, extrapulmonary disease as a way of classifying LAM in terms of the cellular molecular biomarkers. Okay, and that was important in terms of understanding it. However, what Wendy Stiegel has done is, rather than look at a few patients, she's at this stage looked at 721 LAM patients. She had a number of criteria now to look at them. And what she did is basically go by machine learning to divide them into clusters. So what we're looking at now is the clusters that you see, and that is cluster 3 and 2 and 1. 1 is fairly small. So what we did for analysis is we combined cluster 1 and 2 to cluster 3. And the reason this turns out is these clusters are fairly different in terms of different populations of people. And Wendy's been able to do some of the analysis again. We're doing a lot of this by bioinformatics and with Gustavo Pacheco in the lab, be responsible for drawing this whole thing. Okay, the reason that's relevant is cluster 1 and 2 differ significantly from cluster 3 in terms of a number of things. So if you look down here, we're looking at the FEV1 plus or minus mTOR and the DLCO. And if you look at cluster 2 versus cluster 3, cluster 2 responds very well to mTOR. Essentially, you go from negative to a positive effect, which, oops, sorry. And DLCO still shows a decline even with that. But if you look at it compared to cluster 3 shows significant issues with mTOR inhibition. And in point of fact, if you start looking at the clusters in front here, so cluster 2 had patients with TSC, cluster 3 did not. Okay, if you look at the CIS scores, the pneumothoraces were much higher in cluster 3, and everything else is sort of present similarly. But when we looked at the mTOR inhibitor, we were able to define a significant subcluster of 3 that essentially does not respond to mTOR inhibition. So that would be useful in terms of trial design, et cetera, in terms of looking at what we can do to treat those people. Okay, so if we look at our studies right now, a study recently published by Tatiana Worthy from the laboratory was looking at COVID serology. What we find is that even though rapamycin is a immunosuppressive, patients respond to vaccines. It may take, for people following transplant, it may take the third vaccination to get a response, but it did occur. In some patients, they still didn't respond. But in terms of COVID, the response is the same between whether or not you're on rapamycin for both Moderna as well as for Pfizer. Oops, sorry. Okay, we were able to follow CPET and 6-minute walk test progression, and they're stabilized as well by rapamycin. We were able to grade patients being referred to transplantation. So it's another measure of what is occurring to the patient that may be a problem in terms of going forward. What we still find is because the curve is so great, so broad, there are other criteria that have to be used, basically maybe the quality of life in terms of when the transplant occurs. Regarding pregnancy in LAM, I think the most important study is that from Nishant, where it looks like patients could be on rapamycin. Bronchodilator responsiveness is an ongoing study. And the association of small cysts and surface area with DLCO, the studies that's done by Dr. Wen here. And then the mosaicism with Dr. Kwiatkowski, Dr. Darling, in terms of what's happening with TSC, and the fact that the NPs can really pick out which patients should be seen. At one point in time, when we were trying to study mosaics, the NPs were sending patients samples to Dr. Kwiatkowski, and based on the fact that they were mosaics, and even though they were not accurate totally in terms of the genetics, they were fairly close. Although Dr. Kwiatkowski would probably disagree with that. Okay, so what do we have next? So we've gotten LAM program to numbers, to the stage where we have numbers of machine learning to generate cohorts. And what we want to do next is patients still to come out so we can look at the sub cohorts, and we need validation in order to study that. Okay, and we're using addition patient enrollment to validate the cohorts. Next, sub cohorts are being characterized, especially in regard to responsiveness to sirolimus. So there's been another change in terms of what we're doing, and that is the pulse oximeter. If you remember the Atlantic Conference in 2017, what we observed is that oxygen was one of the favored things that had to be fixed. We initially set up a small business innovation research grant to improve measurement of pulse oximeters and improve oxygen delivery. Okay, the SBIRs are done in two phases. Phase one gives a small company, $300,000 to come up with a prototype. Phase two gives $2 to $3 million, depending on your request for proposal. So we started both of them. In the case of the pulse oximeters, the two companies were selected for phase one, but because of FDA guidance on pulse oximeters during phase one, it was decided not to go to phase two. However, based on this is my committee, by the way. You recognize Mary and Beverly and Patricia. So they tell me what to do. And what they wanted for phase one was continuous flow, not pulse, 5 liters per minute for 2 hours, battery operated to permit out of home use, and lightweight, prefer 5 pounds. To tell you, first of all, the 5 pounds didn't work because the batteries were 3 pounds to start with. Okay, but we've been able to get one company now is in phase. Sorry. Well, I think I got 2 here. No. Okay, so phase 2, we want to decrease the weight. So the battery with batteries about 10 pounds. We want to test the functionality on patients. And so far, everyone I've asked has volunteered for this. We want to incorporate an app so changes in oxygen flow can occur over a distance. And that doesn't seem to be any problem. We need to get FDA approval and commercialize the FDA approved device. Okay. This is what we're now at. So we're about 5 months into the protocol. Okay. First of all, the company thinks we should have both continuous and pulse flow operating modes. The reason for the pulse flow is that when you're on planes, et cetera, and you're sitting in patients with LAM, you don't use as much oxygen because you don't desaturate as much. So this saves battery life. So this is going to be incorporated. So right now they have a device that incorporates both continuous as well as pulse flow. Right. Next thing, we want to get FDA approval. That's required. But with everything happening now with the FAA in terms of the SOAR Act, which some of you may know about, where their patients can't get the oxygen they need, what we also want is have an FAA assessment of whether or not oxygen delivery works for the FAA as well. Now, this may change as we go, but at least the company is aware of this issue. And second, they want to improve the interface between the control onboard features, which can involve flow rate, battery status, et cetera. So there's be a lot more given from the device to the healthcare provider. So if you use the device, essentially, you'll get a lot more in terms of whether or not how you're doing and how well it's working. Right? The one person I'd also like to thank is Gary Unger. So Gary Unger is the director of intramural research. So he's the person who doesn't decide, he's the person who gives us the money. And however, what was happening with everything that was happening with NIH, he is now in another job, and his job was controlling the SBIRs. And he did a fantastic job. And I mentioned he got the SBIRs approved in September, in the Friday before I had to present at LAMposium. And that was important because it turns out it becomes less easy to get SBIRs approved now. So he did a good job, and I thought he should be acknowledged for that fact. Okay, we have something else that may be of interest to patients. There was a person, Sean Agbar-Eno, who was a tenure track investigator who was just approved for tenure. And he has a protocol, and what he's interested in doing is studying transplant rejection by LAM patients. He's looking at other lung diseases and other transplants as well, but he's developed a method for early diagnosis and to see whether or not it's possible to have treatment to reverse before the patients develop irreversible rejection. So this is going to be important in general. He will see the LAM patients. We can have people on his protocol as well as on ours. And I think it'll be useful for patients to see how they're doing by stage, a technique that is available in some places. It may be available by commercially as well, but he's developing things that are better in terms of looking at transplants. And he does this from a blood sample. So this may be useful. Again, this is something that is ongoing now. The protocol is approved maybe 2 weeks ago. Okay, so this is what he looks at. That is the donor DNA. So he looks at the DNA that may be arrived from the transplant. Again, he can tell the differences in amount. And if this donor DNA is increasing, the question is whether the patient should be treated sooner rather than later. So that information will be available. Okay, so using cell-free DNA to detect rejection 2 to 4 months before biopsy, and hopefully this will be able to use drugs to prevent the biopsy, prevent the rejection from taking place. These are the contact information. You have the contact information for the NP, which is Andrew Keel, who actually used to work with some of the LAM patients. They may know him. He's now the NP there. You can get his number, whatever. You get the number here for the contact information, but the protocol is available and it's enrolling. It's for other lung diseases as well, but the patients with LAM will be available for his protocol. I'd also like to thank Lisa Hensky. She was able to get 10 years of funding for U01 for extramural investigators. And the way I calculated it came out to probably about, it's 400,000 per year. So it's about $4 million, I believe. Probably should have done my math not on my fingers, but that would be useful in terms of the number of postdocs could be hired for the 10-year period. So thanks to Lisa. And also, I've been annoying Cindy for a while now with how do I do whatever, how do I do it? And she's the only reason that I'm showing this now rather than just seeing a blank screen in front of me. So I thank her as well. Okay. In terms of people now on the LAM team, I introduced and showed pictures of Amanda and Patricia and Tatiana. Gustavo is doing the circulating LAM cells. Wendy is looking at the results of the LAM cell cohort in terms of now going up to the 861 or 81 patients that we're seeing now. So we're trying to get a cohort now that will give us verification to what we found before. Okay, we spoke about Marcus Chen, who he's again cardiologist. He does the imaging, and he devised the low dose CT. Dr. Wen is a physicist who is doing the work on the terms of the quantification of the cysts, etc. Adrienne Campbell is no longer there, except for 20% of her. But she's coming back, and we're able to do the techniques that she devised. And she has people in the lab, in her lab, that still is doing that technique. Tom Darling is the dermatologist across the street in Bethesda. And David Kwiatkowski, is in Brigham and Women's Hospital, Harvard Medical School. I'd like to thank both the LAM Foundation and Tuberous Sclerosis Complex Alliance for their referring patients and their support for the study. Physicians who support our research by referring patients with LAM and LAM TSC to the NIH. Our patients who come here and support our research efforts. Some of them, again, have been here since the start of the protocol, so almost 30 years. Thank you.
Wonderful. Thank you, Dr. Moss. And you even got your slides down, so well done.
Okay.
Yes. All right. Well, all I can say at this point is, wow, that was incredible and so informative. I don't know about you all. You can see all the hearts and the applause that you're getting right now. That was amazing. So thank you. I'm a little speechless, which doesn't happen very often. So
there are the hearts coming up. And applause.
Yes, they're all hearts, applause. Yeah, and thank you for, my goodness, your work over the decades. This is the amount of knowledge that you have gained and shared has changed the trajectory of LAM and research. So thank you. I don't even have words for this. So our community is so fortunate and so grateful, as you can see. So at this time, we're going to open up the chat box for questions. And I have a few that were submitted, and I'm sorry I keep moving from screen to screen because I can't get my screen to do what I want it to do right now. But we talked about TSC, mosaicism. I really appreciate that. That is a question that comes up a lot. There's another question that comes up, and that is the role really of menopause and LAM. And have you seen this in your research? Is it likely that the lungs will stay stable and the disease may not progress? Has that been looked at all within the NIH?
I think Frank McCormick has looked at through the Miles trial. And what he's reported is that even though the rate of decline at menopause goes down, it still declines, and rapamycin was still better than menopause alone.
Got it. Okay, thank you. Somebody was asking whether the sclerotic vein lesions are painful.
Not that we know of.
Not that you know of. Great.
But they're useful diagnostic tool.
Right, right. If someone used to participate in the NIH study in the past, is it worth checking if they're a candidate to come back? They said it's been over 10 years.
They can come back.
Great. All right. Someone had asked, is there any current research regarding the co-occurrence of LAM and LIP? I don't know what that is, but hoping you do.
Yeah, there are some like disease like Sjogren's, which has a lymphatic predominant biopsy. Okay. So some of our patients have had Sjogren's, and we've had patients that have had both LIP or the equivalent of LIP and LAM. And it depends on how bad the Sjogren's is. The major problem that our patients have had has been dry mouth and dry eyes, et cetera. So there are treatments available. And fortunately, NIH also has a Sjogren's clinic. So they're associated with a dermatology bench because dry mouth gives more deep tooth decay. Okay.
Right.
And I've been a consult for some of them where they've had cystic lung disease, which occurs with Sjogren's. And in a lot of cases, it looks different. It is not, but in some cases, it mimics LAM. So it could be the LAM part rather than the Sjogren's. Sjogren's also does not have cystic lung disease in all cases.
Good to know. Thank you. Somebody was wondering how many CT scans they have to do in a year.
Um, well, first of all, I correct have to do. So the reason the consent signs is everything is voluntary. Okay, so the way we're organized now, the first CT scan will be done when you've come in, so the first time, and that'll be a regular CT scan. And what we're trying to do now is every year post that, we'll do a low dose. Okay, so that's equivalent of a chest X-ray. And we think that's important because if we can pick up changes in the CIS score, changes in other manifestations of LAM, such as the AMLs, for example. So we prefer to have that procedure now. And again, it's equivalent to a chest X-ray beyond the first year.
Right. Thank you. Now, we get this question from time to time at our office, and people wonder if you are completely asymptomatic. You've been diagnosed with LAM, but you're asymptomatic. Can they still participate in the research protocols? And are there benefits to doing that at this point?
Yes, because you're asymptomatic because you don't feel it. Okay. But if you look at PFTs, the PFTs may be normal and the CT is really not. So I think at that stage, it's worthwhile seeing where the patient is in terms of the CT. The reason the PFTs may be normal is the range of normal is fairly broad. Okay, so unfortunately, in a way, CIS scores are not. So you shouldn't have a significant CIS score when you're normal.
And is there a benefit to starting sirolimus or other medications while you're asymptomatic to potentially inhibit that further cystic growth?
So I think I would go part by the CT scan. So if you look at the criteria for the mild trial, for example, even though they were trying to get people that may have been asymptomatic, but the idea was to treat people early. Okay, if the PFTs are abnormal, et cetera, you may want to treat even though if you're asymptomatic. So it depends what the numbers are, but there is clearly a good reason to see a pulmonologist if you're asymptomatic and look at the CT scan.
Right. So it's not just one thing you're looking at, right? It's a multifaceted, yeah. And then somebody was wondering, so you talked about these cohorts, which I thought was fascinating. And of course, that's because LAM patients and you have been looking at this for a long period of time, which is amazing. So somebody is asking, can you enroll in the post-LAM or rejection studies? I was one of the early patients and have many problems with sirolimus, but they insist that she stays on it. I'm not sure I totally understand that, but yeah.
I don't, yeah. So if
Yeah.
you're, some patients with transplant have developed cystic lesions that respond to sirolimus.
Mm-hmm.
And so if you're having a problem that is cystic in post-transplant, that's a different problem than rejection. Okay, those patients are treated with sirolimus if they have the cystic changes. That answer the question, you think?
We'll find out.
Okay.
And yeah, she can keep asking and we'll try to
You know where I live.
a little more. Yeah. So somebody's asking, can HRCT scan use the ultra low dose radiation, or is that for regular CTs only? I know a lot of us would love to have access to these low dose radiation.
I think most places you go to, most medical centers will give you a low dose CT, but it's not what the ultra low dose that Dr. Chen has. We're trying to get it down to an algorithm, which is what Dr. Wen may do, so that it's something that different places can follow. The other problem is, even though the cysts now look very good in terms of what you're looking at now in terms of a low dose, we're still trying to figure out whether we can see everything. That's the issue.
Right, right. Now, We hear a lot of discussions, and this has gone on for time immemorial about cancer and LAM. And so someone was asking, how can LAM researchers be certain that traditional cancer treatments won't help a LAM patient merely because the cells are benign? If they metastasize and they're destructive, shouldn't we be doing more to shrink the cyst rather than just blocking the mTOR pathway?
Well, so the mTOR pathway is probably blocking the cysts as well, so that's good. But we've had patients that have had more traditional cancers and have been treated with the drugs, and we have not seen the LAM, the rate of decline decrease. Okay, so
Increase.
we're following LAM during this, and what we normally suggest is that, for example, with breast cancer, that breast cancer in LAM, you make sure you go after the breast cancer first in a lot of cases, depending on what type of cancer it is. So you sort of handle that and then come back to the LAM. I would
Does LAM cause osteoporosis?
say again.
Does LAM cause osteoporosis? Do we have a higher incidence of that? Do you see anything like that?
We see osteoporosis in LAM. When we first started doing we now look at bone density in LAM for that reason. That was because patients at that time were told, you have LAM, sit down on the on the couch, and it that's it. Okay, and what we found is patients at that time had more osteoporosis. It would respond to the usual drugs, which is Fosamax on that time. I would just say, just go along with how you treat osteoporosis. I don't think the LAM causes it.
Got it.
That's an opinion,
Got it.
but it
Okay.
doesn't respond to those drugs.
Are we any closer to finding the answer to the second arm of the printing press of LAM cell production? I know it was being studied for cancer patients. Do you know what they're talking about on that? I'm not familiar with that term.
Second arm. I don't know.
Sandra, if you want to jump in, if you're still in the
Sure, I'm here. Thank you.
Yeah.
I'm so impressed with the presentation. I was looking at another LAMposium video that was talking about the printing press, and they had a little cartoon where there were two arms, and they were saying that the sirolimus stopped one of the arms, but there was still continuation of the printing going on, and that they were actually using a medication to work with cancer patients, but they weren't sure about the toxicity for LAM patients. And that was in one of the LAMposium videos.
Yeah. No, so yes. So part of the problem, as you could probably tell from one of the cohorts, is that the disease still progresses on mTOR with mTOR inhibition. So there are other drugs out there, but we haven't tried it. Other people are trying it.
Thank you.
So, of course, we have LAM patients that are across the world. Unfortunately, LAM is universal. So for people not living in the US and when they don't have any LAM specialists around, do you recommend doing regular chest and abdominal CT scans and pulmonary function tests to monitor the disease? What type of guidance for someone who's having to advocate for themselves internationally would you give them in terms of what they should ask for?
It depends on the country.
Okay.
Okay, and the reason is you could probably tell from what I showed. In addition, if you put up the LAM centers in different places, you'd probably see the same thing. Different countries have it, and I'm not sure what the number is. You can tell that better than I do right now. But there are a lot of LAM centers that we're working with that are outside the U.S. So I first look at the country to see whether you can help them. So when our patients go to different interesting places to go, as I've said, there's usually a LAM doctor around there that I tell them about and call the doctor so that they have somebody, if something goes wrong, somebody that knows the disease.
Right. Thank you. Sharon asks, and I may be able to answer this one, can I get a transplant if I'm not an American citizen? And we've looked into this before. Yes, you can. It's all about dollars. And that's really what it boils down to. I don't know if you have anything to add to that, Dr. Moss, but
Nope.
Yeah, that's my understanding. Okay, and you've got a big thank you from Kelly to you and your team. Somebody's wondering how do they apply for the NIH study, and Amanda answered that for us. Thank you. Let's see. My doctor at U of M says she has not seen bone lesions in a sporadic LAM patient, but I and another LAM friend both have bone lesions and high calcium levels and low white counts. Have you seen this?
Uh, so the, I would, I'm not sure what they're talking about. First of all,
Okay.
sporadic LAM patients do have some bone lesions. Okay. So remember when I gave the IQR, which is the range of bone lesions, it was like 1 to 3, but that's the first and third quartile. It goes a little bit further than that. So we've seen, we would say up to 6 sclerotic bone lesions of patients that we think are sporadic LAM. Okay. We're still trying to see whether or not they're a mosaic of some sort. And again, LAM is a mosaic, so we don't know to what extent that becomes part of the problem in terms of using that as diagnosis. But we're still trying to figure out a little bit more about where they are found and where they're not.
Great. Someone's going back to the menopause question, and this comes up a lot too, and I know it's been discussed over the years. You know, this person has had breast cancer, they've had all their estrogen removed, they've had aromatase inhibitors, and they haven't had progression of LAM. Has there ever been a study, or have you all ever looked at that, whether those things are truly effective in halting or slowing down the progression of LAM, estrogen suppression?
Um, so menopause by itself doesn't, right? Because of what a study from the Miles trial. Okay, but I don't know whether or not if you get more severe suppression, whether that would make a difference. We haven't studied it.
Not been studied. Yeah, that would be a really important question.
There was another study that Dr. McCormick was planning and decided not to do it because rapamycin came out at the same time. So then what you're doing is you're comparing everything to rapamycin. I think what would be useful is when we get the cohort that is mTOR insensitive, and mTOR inhibitor insensitive, that would be very useful for us because then you know the people that can't respond to anything else. So you're giving them this, and then you may be able to put it. It's sort of like the same way they were using VEGF-D. It was really high. It was really high. It was good, but when it wasn't really high, it didn't help you as much.
Right. Okay. And this is a question that's got some words in here that I'm going to try not to butcher, but it says regarding sporadic LAM, could these women have extreme mosaicism due to mutations at the embryonal stage with lung-only involvement? And secondly, has the hypothesis that pulmonary lesions in sporadic LAM arises from metastases from myometrial C cells no longer popular?
So Jane Yu has very interesting paper which showed that the uterus may be responsible for the cells that go to the lung. Okay, so some of this I'm not going to answer because I'm not sure we have that. But also, I don't really know what happens early on, right? We haven't really done those studies.
Okay. Okay, and we did get clarification on the question about rejection. And so she's wondering, she is post-transplant. She has issues with staying on sirolimus, and she's wondering, could she be a part of the study that Dr. Sean is doing?
Yes.
Okay, all right.
My impression is that the protocol was improved. He can be with us or separate from us. When I've spoken to him, he lives like one floor up. And from his point of view, he'd love to see the LAM patients. He's spoken with 3 of them so far in terms of what he's doing. And it probably would help both ways. And that is from his study to get group that would really participate, which is what the LAM patients have done. Meanwhile, we'd see them here as well.
And I will tell you all too, in April, I think it's April 29th, and we'll have it on the slide here in just a few minutes. Dr. Sean will actually be coming and talking to us about identifying rejection post-transplant and about his study. So please be sure and watch for that. It'll be a good time to dive in deeper with those questions. So if someone is post-transplant and had COVID, and then has struggled since then, can anything help their lungs?
I don't know.
Don't know. Okay.
So but there's another group at NIH studying long COVID.
Mm-hmm.
So I think it's worthwhile, again, getting into the system and seeing whether something could be done.
Great. Thank you. And speaking of CIS score, what is an average CIS score range at time of transplant? Is there such a thing?
So when we have a paper out, we looked at the when patients went 1 year before they went to transplant, because when they're actually going to transplant, they're not going to go to NIH or on a list or whatever. So 1 year before, the curve had a peak that was very broad, but it was around 50%
Mm-hmm.
in terms of CIS score.
Okay.
But there's so many things that go into that. It depends on how quality of life for the patient, what they want, et cetera. So
Mm-hmm.
you don't take one number.
Right. Right. And then I'm still getting some post-transplant questions. For those folks that are asking those, I am going to hold on to those, and I'm going to take those and refer that to one of our post-transplant doctors that may be able to guide us a little deeper on those things. So I don't want you to think I'm ignoring you.
But
Mhm.
Dr. Sean would be glad to answer those questions too.
Yes, thank you. Yes, absolutely. And I will include him as well. So is LAM considered cancer? Here's the age-old question. Let me ask this differently. Is LAM considered cancer by Dr. Moss? Because depending on who I ask, that answer differs.
So yes, so I have a paper. Dr. McCormick is one of the co-author, first author, I believe, on it, and he says it's cancer. It's a neoplastic cell, meaning it's a new cell in the body. Okay, it metastasizes, which everyone agrees to. The only thing standing in the way is the fact that it looks benign. So it doesn't look like a cancer
Right,
cell looks.
right,
But
right.
that's it. How it behaves. Now, in terms of the fact that in most people it's a chronic type of cancer, but in some patients with LAM, these cells are much more active, and patients need a transplant very soon after finding out they have the disease. Okay, so my take would be same thing like prostate cancer. The usual word used to be that men die with rather than of prostate cancer. But as you may know from people that know, people also die of prostate cancer. So I think it's it, it it's mixed and bag, but it
Right,
depends what your disease is doing.
right. Again, we always say LAM is an N of one, right? We all
Right, exactly.
very unique situations, yes. So has metformin been studied in LAM for mTOR inhibition?
I don't know.
Oh no. Okay. They're saying it
If you,
indirectly suppresses mTOR via AMPK activation.
right,
So
exactly. That's
yeah.
been known from a LAMposium many years ago. The
Mhm.
the uh, the signaling pathway with mTOR was shown with their mTOR was put in there, and metformin was part of that as well.
Great. Let's see. While I don't advocate aromatase inhibitors, wouldn't this be useful to study for severe cases?
Yeah, well, the answer is yes, but let's
Yeah,
find out whether we can get the population where you do it because it's reasonable for you.
right, right. And then who would someone is asking again on that long COVID study that you mentioned, or other studies that at their NIH, who would they call to find out about that?
Uh, I can find out for you.
Okay,
Really want to know who's enrolling right now. And
right,
if that
right.
person you can give them my email address, so I'll answer
Okay,
with the other person.
okay, great. And then what are the current recommendations for those of us that are still not meeting the current criteria for diagnosis, but are presumed to have LAM and are mild but with worsening symptoms? Should they come to you? Can they come to you, or do they need to actually have that diagnosis?
No, no. So the patients in the 96H100 protocol, the second one I described, those are patients who really don't have a diagnosis yet. So we have the record, and we're doing studies to get better biomarkers to distinguish between LAM and other cystic lung disease. And once we have those, we're going to go to samples that we still have and find out whether or not it gives us a diagnosis. So if the person wants to come back and follow up, they're more than happy to see them.
Great. Wonderful. Thank you. Are there stages of LAM, and how would you describe those?
It's a continuous disease. You can you can call mild, but everything runs into each other. I think the only reason why it's important in terms of stage is that at a certain stage you probably need oxygen, other stages you don't. But that it's really what you need when you look at the tests, right?
I pass all the stages. I am the last pages that I wait for transplant. From the beginning, I have 18 pneumothorax, and now I am in the oxygen, and now I wait from transplant.
So you know what stage you're in. Yeah. Yeah. Sorry.
Yeah.
Yeah. Yeah. So if you're eligible to enroll in one of the LAM protocols, how long is the usual timeline between reaching out and visiting the NIH clinic?
Amanda's picture up there, and whatever I say, Amanda's going to probably say it's wrong. So,
you want me to speak to this, Dr. Moss?
no. I think part of the problem is right now is that we have a lot of people coming in, and the NIH has had some problems because of everything else going on in terms of personnel, et cetera. So I think it's difficult to put a timeline on it. I would say have the person talk to me, and I could probably find out what would happen. I don't want to give a number that's going to be wrong by definition.
Got it. And then, are there any future studies in the works to look at long-term sirolimus treatment and influence? For example, if it stops working as well. So they've been on it 10 plus years. And I think this is really an interesting question. I'm somebody who's been on it over 20 plus years. And so, what is that efficacy lifetime? Are there studies that are being considered for that?
Well, we're just following our patients. So some of the patients are on, in the case of Mary, she's probably been on it more than 10 years. I forgot how many years it is. And again, she tells me I can tell people that. So this drug is still working. What may be different though is the dose that you need. So some drugs you develop resistance in terms of how much you can give them, but they will still respond to more. There may be more side effects in some ways, but what you're really interested in is preserving the lung, and we can treat some of the side effects. So it depends on the person. Again, personalize it. We'd be glad to see people that way as well.
Right. Okay, thank you. You know what? I think we actually covered it all, which is amazing. So if you have future questions, if there are things that you think of, please reach out to us at patientservices@thelamfoundation.org, and we will certainly help you. And Mary chimed in. She's now on 7 milligrams of sirolimus. So again, talking about, personalizing that dosage. So,
and what she would say also is that the reason she went up that high is it then stabilized her. Below that, she would stay on it. She would still have decline in function.
Right. I appreciate that. I do have a question too. So the whole discussion of trough levels comes up a lot. What is the relationship between trough levels and sirolimus? Do you all look at that? Is that a part of your protocol?
Everyone will get a trough level when they come. Okay.
And is there any relationship between someone's trough level and efficacy of treatment on sirolimus?
Yes.
Would you like to elaborate on that at all?
No. The reason is there's,
Yeah.
I think, so in general, 2 milligrams worked
Mhm,
statistically in miles. Okay.
mhm.
Uh, my impression is that some people that are on 1 milligram trial had to drop out. So
Right.
some were more help. And I think in some others, maybe going higher, as has been done with Mary, may be useful in terms of if the drug's not working, try a little bit more and see if it does.
Right. Okay. Thank you. Well, Dr. Moss, it's been a pleasure to have you and your team here this evening. We're getting lots of thanks that are coming through in our chat. We are so appreciative of you all taking the time out of your evening to be with us. And I am hopeful that as a result of this, that more in our community will indeed join you at the NIH to participate in these critical research protocols. And I was going to say, let's give a virtual round of applause, but it is coming in spades. So it's been coming for quite a while. Just I hope you know how much we deeply, deeply appreciate you. So we've got a couple more slides here that we will. I'm going to let this go for a minute though. This is beautiful. All of the thanks, and I hope you can see that and know how much you and your team is greatly appreciated. So as we close the presentation portion of this evening, I do want to remind everyone of the importance of tissue donation in furthering LAM research. So if you are a LAM patient living in the US and you are having an upcoming surgery of any kind, I know Dr. Moss even tonight mentioned LAM cells in the ovaries, and I thought, oh my gosh, I had an oophorectomy years ago, and I wish I would have thought about that and donated the tissue. These are all very important. So please reach out to the National Disease Research Interchange directly or to the LAM Foundation for more information. Donating is a simple process and it has an exponential impact on research. So a few quick calendar notes. On April 29th, as I mentioned earlier, our Circle of Hope Transplant Support Program will host a webinar on recognizing and monitoring early signs of lung transplant rejection. And that will be with Dr. Sean Agbor-Eno, who Dr. Moss spoke so highly of this evening. So mark your calendars for that. In June, we celebrate our Worldwide LAM Awareness Month. And on June 2nd, as part of that, we will host our popular LAMposium session with Dr. Nishant Gupta on LAM 101, and it's those key concepts and common challenges. And then on August 5th, we will have a long-awaited presentation on menopause and LAM. So for those of you tonight who were asking questions about osteoporosis and other hormonal influences or lack of hormones, if you will, as we get older, this will be a presentation that you won't want to miss. So again, thank you all for joining us. And we appreciate you being here. Again, many thanks to the NIH and the team, Dr. Moss, Amanda, Tatiana, Patricia. We're so grateful for you. And we wish for you all a lovely rest of your evening. Good night.
Good night, Cindy.
Good night, everybody.
Good night.
Love you guys.
Take care.